I'm here to talk to you about something called disruptive innovation. It's a concept in the world of business. It's what I've been studying for the last 6-7 years of my life. And it's actually been a very useful tool with which you can understand how industries evolve over time, especially evolve in a way that delivers more affordability and more accessibility to its customers. And that, of course, is something we desperately need in healthcare. And so I'm going to talk to you about how disruption has affected other industries outside of healthcare. And then we'll see what kind of lessons we can draw from that and start applying to healthcare. And then I'll sprinkle throughout examples of some of the major technologies and innovations that I think are really disrupting healthcare. EBMS has been very kind to provide you all with a copy of a book that my co-authors and I started writing back in 2006. And it was all about our predictions using this disruptive innovation framework that I'm going to tell you about to predict what the future of healthcare might look like. As I said, this was written in 2006, at least that's when we started. It came out in 2009. And when we were doing research for the book, I mean, Barack Obama wasn't even the leading candidate for nomination of his party. So obviously things have changed quite a bit since we were doing the research. And there's a funny thing about writing a book about the future of healthcare and the future of anything, and that is at some point, somebody can just look around and see if your predictions were right or wrong. Now, the good news is, and I'm proud of the fact that a lot of our predictions were spot on. And I think that really shows the value of what this concept of disruptive innovation offers. And I'm hoping that you guys will leave today with some idea of what this language, this terminology means. And of course, if it interests you enough, absolutely feel free to dive into the book for more information. So as I said, I'm going to use examples also from outside of healthcare to help illustrate what disruptive innovation does to an industry or to products and services that we all know and use. And let's answer this question before we even answer how we get to affordable healthcare, and that is, how do we ever get to affordable computing? How do we get to the days when a laptop computer is available for just a few $100s, and the price actually keeps coming down? And it wasn't even that long ago when computers looked like this. Filled rooms as big as this, extraordinarily complex, extraordinarily expensive, and really not accessible to any of us. And you were really fortunate if you actually got near one of these machines, because it meant you were an expert engineer or technician, and you were operating these machines on behalf of other people who had tough computing problems that they would give you. And next to some of these machines, you might find this sign. Now, this sign is in fake German, so even if you don't speak or read German, feel free to give it a read. I'll give you about 20 seconds. Now, this sign is actually known as the blinking light sign or the blinking lights poster. It actually is well known among a lot of tech circles because you would find this sign next to a lot of expensive pieces of equipment, robotics, and mainframe and computers. And basically all it's saying is, look, if you're not an expert, don't touch, just stand there and watch the blinking lights. And so it's quite amazing when you think about where computing used to reside, in this exclusive domain of experts. And you fast forward to today where computers really can be used by pretty much anyone. And those of you with little kids or little grandkids have experienced this very fact that computers are highly usable and very intuitive for small children. And not only can computers be used today by almost anyone, they can be used pretty much anywhere. So no longer stuck in big mainframe centers in these large air-conditioned facilities, but really portable in all parts of the world. So how do we get from there to here? So what I'm going to do is use the set of concentric circles as a model to illustrate this progression. And basically, if you go back far enough, even before the days of the mainframe, the world of computing was in a state that we would call highly decentralized. That is, it was actually affordable and accessible to a lot of people. And it took the form of a slide rule. And those of you with gray hairs in the audience might remember what the slide rule was. But it's something that you could carry around on your belt or in your bag. Or basically, if you ran into a computational problem, you take your slide rule out, make your estimations, get an answer. And essentially, in those days, what we were doing was we were carrying around a solution to our computing problems with us in our pockets. But as often happens when a technology comes about, there's a centralizing effect. So what that means is that technology brings it to the center where all of a sudden only a few people have access to it. So what these circles actually represent are tiers of the marketplace. In the center circle, you've got people with the most money and the most expertise. And they're typically the first adopters of any new product or service. And then as you move outwards, you start to reach people with less money and less expertise until you get to that outermost ring. And these are the people on the outside looking in. These are the people who are the last adopters of any new product or service and have to wait until something is easy enough, simple enough, convenient to use, or affordable enough before they get a chance to use it. So the mainframe computer really took us in the opposite direction, right? It was, of course, a technological advancement, a marvel that was far, far faster and more accurate than any human being could ever hope to compute using a slide rule. But the dramatic trade-off was now suddenly it was accessible to very few. And you were lucky if you worked at a big enough corporation that had a big mainframe center, or you happened to be a student or worked at a university where you had a mainframe lab, but otherwise you were really shut out. And unlike today, you weren't the one that really operated the machine. You didn't get to touch the computer. Instead, it was somebody that ran the jobs for you. And no longer were we carrying around the solution in our pockets, we actually had to take our problems to a central solution source. And that basically meant carrying a stack of punch cards over to the mainframe center where that person, that engineer, that technician, that expert would run the job for you. And it was actually that sheer inconvenience and cost, lack of access, that drove successive waves of decentralization in the computing industry. So what I mean by decentralization is simply a device that takes computing to the next wave, the next ring outward. And that took the form of the mini computer. The mini computer was still big in today's terms, but certainly much smaller than a mainframe computer. It was about 1/10 of the cost of the mainframe computer, and therefore more affordable, more easily available. And it was actually a great solution for people who had computing problems, but didn't want to have to go to the mainframe center each and every time. And so you buy one of these machines and have it in your own building or even on your own floor. The problem was the mini computer wasn't as good as the mainframe computer. It wasn't as powerful. It couldn't do everything that the mainframe could do. And so you could only use it to solve some of the simpler problems. And yet that was an acceptable trade-off for people who needed this machine to do some of their day-to-day problem solving. All of the complex problems you would still take to the big mainframe center. And so that's the way the mini computer arose, to solve simpler problems at a more affordable price for people who valued that convenience and affordability. But as often happens with technology, it got better over time. That mini computer started to do more and more complicated things, and pretty soon, only the toughest computational problems were reserved for that big, expensive mainframe computer, and everything else was done by the mini computer. But then some of us wanted to take computing home with us, right? We didn't just want to use these machines at work, and that drove the personal computer. And the PC, when it first came out, just like the mini computer in the previous era, was a pretty simple device. In fact, a lot of people marketed it as a toy for hobbyists and children to play games on. But some people realized, well, you know, I could use this to do some basic word processing, some simple spreadsheets, and yeah, do some gaming. But it could take over some of these very basic tasks over from the mini computer at work. And from there, it got better and better over time and started to take over some of the tasks you used to only be able to do on your workstation. And pretty soon, the PCs themselves started showing up at work and showing up in server rooms and acting as workstations and taking over that role that the mini computer used to play. And only the toughest problems were now reserved for the mini computer or the mainframe, but everything else was done by the PC. Next, we wanted to take computing on the road with us. And once again, when laptops first came out, there were some pretty extreme trade-offs. People had to live with limited battery life, smaller screen sizes, and yet it was good enough for people who actually needed some computing power on the road so that they didn't have to remain tethered to their office machine. And once again, everything else that you wanted to take care of that couldn't be done by the laptop, you could always do on your desktop at home. But as the laptop got better and better and more powerful, we started to transfer our work over to the laptop PC. And the desktop was really reserved just for the more complicated things that your laptop couldn't do. Once again, the marketers got wind of this, realized what they had on their hands, and started marketing the laptop PC as a desktop replacement. And then finally today, we're computing more and more using our tablets and our smartphones and these devices that we can carry around once again in our pockets. And if history holds, what we are seeing today is that people are really doing some of the basic things they used to do only on their laptops, on their phones. Web browsing, messaging, on top of the phone calls that we used to rely on our phones to do. And once again, those technologies will get better and more powerful over time, and we'll see as customers gradually shifting more of their activities from laptops over to their portable devices. And we are already seeing this play out in the market because sales of laptop PCs as well as desktops have plummeted. And so we've reached this decentralized era, this outermost ring, where tablets and smartphones are not only much more affordable versions of computers, but highly convenient and available to people who need computing wherever they are. And so unlike the old days of the mainframe where we had to take our problems to a solution source, now we're carrying around the solution to our problems with us at all times. So a couple of observations about this history of computing, which hopefully is all familiar to you, or at least several phases of this that we've all lived through and benefited from. The first observation is actually there was a new set of companies that led each wave of decentralization. That is, there actually hasn't been one dominant computer company that led all of this change. In fact, if you were a successful mainframe computer company over there in the center, chances are you weren't even around to see the days of the mini computer. And if you were a company that was wildly successful and profitable in the days of the mini computer, chances are you weren't going to be very good at building and selling PCs. So why is that? Why is there such turnover in leadership in this industry as well as other industries? Well, I'll talk about why in a second. The second observation is that with each successive wave of decentralization, as we move from one generation to the next, we spent far more percent as a GDP on computing than we ever did in the generation prior. But of course, nobody ever complains about that because we've all extracted enormous value from the spending. Contrast that with the debates that we have in healthcare, where percent of GDP and overall spending is really the focus of attention. And I think that's a mistake. It comes out of the fact that we have very little value coming out of our spending. So the bulk of my talk, and what you'll find in the book, is that the focus is on the delivery side. How do we change healthcare delivery so that we can, in fact, deliver more value? And all of this discussion that's going on in Washington and other circles about how do we pay for all of it becomes a lot easier to answer, because by then, hopefully, we can make healthcare affordable enough that getting everybody covered is not the issue. So this is the model of disruptive innovation. It comes out of Clayton Christensen's work, who was one of the authors on the book as well. And basically what he said is, for any industry, for any product or service, I can show you its performance versus time on this graph. And it's quite simple. There's two trajectories that I can show on this graph that show performance improvement over time. The first, here in red, reflects customers and their ability to absorb or use improvements in performance over time. So it slopes upward, right? Because customers can learn over time. If you just think about how you interact with your own smartphone and how over time you probably learn how to use more features and more functionality that's built into that phone year after year. But there is, of course, a spectrum of customers out there represented by this bell curve. So at the top, you've got power-hungry users, people who are never satisfied no matter how much performance is actually built into their phone. They always want the next generation device. But at the same time, they're also usually the ones that are willing to pay for it, right? So those people at the top of that bell curve are typically the most profitable customers and the most loyal customers to a company. Meanwhile, at the bottom of that bell curve, you've got simple customers with simple problems who can actually be oversatisfied with very little. There are a lot of people out there who say, I don't really care how many more bells and whistles they add to my smartphone. I just want one that can make calls. And if you're going to keep making me pay more and more for expensive phones with features that I can't use, I don't want, or I don't even know how to use, I'm not going to pay for it. I'm going to stop buying those phones, or I'm going to buy something else that's cheaper. That's the spectrum of customers that's sitting at the bottom. But of course, this red dashed line represents the average. Now, there's a second trajectory of performance improvement here in blue, and this reflects companies and their ability to introduce innovations year after year and move up that performance graph. And basically what this reflects is that every company wants to build better products. They want to add more bells and whistles. They want to make their products better. And they do this primarily because not only does a company naturally want to make good products, but they are also typically more profitable products. As I said, if you're chasing the customers at the very top, it usually is good business practice. Those are the customers that are willing to pay continually higher prices, give you higher margins on your better products. And so it makes perfect sense for a company to want to build your best products for your most loyal customers and your most profitable customers. And so that's what that blue trajectory represents. Now, as you move up that graph, a company can introduce incremental improvements year after year. Sometimes they can be big revolutionary leaps forward. But what all of these innovations that a company normally introduces have in common is that they sustain this blue trajectory upward. And that's why we call this form of innovation a sustaining innovation. So this is a label that comes out of Clayton Christensen's work. It's something that we explained in the book. But a sustaining innovation is basically something that comes naturally to any company. It is basically building better products that you can sell for higher profits to your best customers. That's sustaining innovation in a nutshell. It's something that pretty much all successful companies are very good at. But what you'll see in these sorts of innovations is that it's almost always coming out of a leading incumbent. An existing company that already leads the industry will figure out a way to introduce the next generation product or service. On the other hand, there's a different type of innovation called the disruptive innovation. When that shows up, something very different happens. So first of all, if you look at this graph, what you see is that that blue line eventually outpaces that red line. What it's saying is basically that eventually a company will start packing in more bells and whistles into its products and services that a growing number of customers are willing to pay for. And so you have more and more customers starting to look elsewhere and saying, there are features here that I no longer want to pay for. I want to find something that's more affordable, something that's more suitable for my uses, something that's more conveniently available or simpler to use. And that's what opens the door to a disruptive innovation. So a disruptive innovation appeals to one of these outer rings of customers simply because it's more affordable or easier to use. And we differentiate it from the sustaining innovation because it is not trying to make something that already exists better. It is basically trying to introduce something more affordable or easier to use. And that's very different from the normal path of innovation that most companies pursue. The other interesting thing about disruptive innovation, though, is that it's almost always introduced by a new entrant to an industry. So when I said before that sustaining innovation is what existing companies are very good at, the question on the table is who's going to build a better product that sells for higher profits to your best customers? If that's the case, I would almost always bet on an existing incumbent. On the other hand, if the question on the table is who's going to deliver more affordability, better convenient accessibility, I would almost always bet on a new entrant. So let's take a deeper look at why those odds of success are so different when you're talking about sustaining versus disruptive innovations. So let's pretend and go back to this computing example and put yourself in the shoes of the CEO of a leading mini computer company like Digital Equipment. Digital Equipment was one of the most admired companies in its heyday, based in Massachusetts. It was really the dominant company of the mini computer era. And your business is in charge of selling these mini computers at $250,000 a piece at 45% gross margins. And you'll have people in your company bringing to you proposals to build the next product that you guys will line up against. And some of these product proposals will promise, business plans that are going to sell these products for $500,000 a piece at 60% gross margins. On the other hand, you have other people in your company saying, no, we can't just keep building mini computers. Look out your window. People are starting to buy PCs. We can't miss that wave. So it's not as though you didn't see it. The incumbents did see the PC coming, and they got these product proposals, including on your desk, and you saw machines that would sell for $2,000 a piece at 40% gross margins, and they would quickly drop to 20% margins because they were so much easier to build. So just from a financial standpoint, it becomes easier to see if you've had a history of success selling these sorts of machines up here, it's very tempting to want to continue building better and better machines that typically sell for higher profits, rather than intentionally build something that's going to sell for lower margins and lower profits. But it's not just about the money. If you think about the people that work for you, the people that you had paid a lot of money to recruit, train, and retain, and keep at your company at Digital Equipment, people like your engineering workforce were brought in to design and build these very expensive and complicated machines like mini computers. If you task them suddenly with building plug-and-play devices like the PC, it would be a pretty poor use of that talent base, but they'd also probably just revolt and seek greener pastures. At the same time, you had salespeople that worked on commission. And if you told them that, we don't want you to sell, these $500,000 machines. We want you to start selling these $2,000 machines. They would probably revolt because, of course, their commissions would disappear. But perhaps most importantly, if you went out and polled your best customers and asked them, what do you want from us next year? You would actually never have gotten any signal back that PCs reflected a wave of the future. Because your leading customers at Digital Equipment, the people who were most loyal, who paid you the most, and bought the most computers were people like banks and insurance companies, government agencies and hospitals, big entities that needed that computing power. And if you asked any of them, what do you want from us next year? They would all have told you, we need the next generation mini computer. That's exactly what they needed to run what they did. And so it never made any sense to build a PC because that PC looked like a toy next to the mini computer that your best customers were demanding. So in the shoes of the CEO at Digital Equipment, why would you ever intentionally build a product that made you less profit, that would cause your workforce and your engineering force to leave, and in order to build a product that your best customers couldn't even use? So this history of success at Digital Equipment, and really any company, almost shackles you to that history, that past history, and to keep you doing what you've always done. And puts blinders on. Sorry, a little joke with the horse. But puts blinders on so that you can't really see a disruption when it enters your market. And that is why it's almost always a new entrant that comes in, figures it out, and eventually displaces you. And unless you think that this is just high tech or computing, we've actually seen this time and time again. So on the left-hand side, we've got just a sampling of some of the companies that that were very successful at one point, but found themselves disrupted eventually by companies in the middle. Now, the companies in the middle, though, are themselves being disrupted. So rarely is disruption just a one-time event. It's not just one company cropping up and displacing another, but it happens time and time again. And that is sort of what I explained in the computing example, where we saw wave after wave disrupting one after another. And so the companies in the middle, even though they may be very successful today, are quickly finding themselves being victims of disruption by the companies on the right. So Toyota, for example, which grew out of disrupting the US auto manufacturers, are themselves being disrupted by manufacturers from Korea, China, and India. So let's turn to healthcare. I can't think of a more perfect example for the mainframe model than our general hospital. It is the centralized solution source where we expect our patients to bring their problems. It is where we have amassed all of that expertise and all of our talent together and all of that technology in order to fix the most complicated problems that we face in healthcare. But it comes at an extraordinary cost, right? It is very expensive to put one of these together and to operate it. And the problem is that this gold standard is very difficult for those people on those outer rings to access. If you live in a big city or you have a lot of money, and especially if you're insured, it's less of a problem because you're probably more in that center circle. But here's the problem, man. That gold standard is really not available if you happen to live on the wrong side of the tracks, as I said. If you don't have money, if you're not insured in healthcare, what good is that centralized solution source? What you need is something that brings care outward into those outer rings. And so this is a picture from Rio where we're going to see the Olympics, but I doubt we're going to see this picture. Now, in the business world, we have a very polite term for those people on the wrong side of the tracks. We call them non-consumers. So non-consumers of healthcare, in a large part, are people who can't afford healthcare because healthcare is very expensive. The question is, can we deliver healthcare in a more affordable way so that we can start to permeate some of these walls that sit between these populations? Non-consumers is actually an important point because it is also the term for what we call these outer rings. Those people on the outside looking in on that graph of concentric circles I showed you earlier, those are non-consumers. And disruptive innovation is all about targeting non-consumption. But non-consumption in healthcare is not just about trying to make care affordable enough so that even the poorest of the poor can afford it. No, there are a lot of non-consumers out there. So there are people who live in geographically remote areas, in large parts of this state, for example, where you can't really sustain a hospital. Now, the government has made an extreme effort to support safety net hospitals, but that's with a great amount of subsidy. left to their own devices, most of our hospitals will probably go out of business. Is that really the right solution? It's great for humane reasons. We want hospitals around because they serve a great need to society, but at the same time, it's not really sustainable. Can we find a more effective business model to deliver care to populations like this? And if you think it's just the poor or the people who live in these remote villages in Alaska, many of us have actually probably been victims of non-consumption in healthcare. We're all very busy, and even though you may work for a healthcare organization or something related to healthcare, I'm hoping you're all insured, or at least wealthy enough to pay for your healthcare if you haven't. You all have access, I hope, to doctors and hospitals. But you will still go through an inner monologue whenever you get sick or feel sick. And you will ask yourself, am I sick enough to really want to engage the healthcare system? Because it means hours of waiting at the doctor's office, more hours of waiting potentially at the pharmacy, and it means finding daycare or a babysitter. And basically, we often will deny ourselves healthcare and at least delay it until the point where we're so sick that we have no choice but to seek medical care. That is actually a symptom of a broken healthcare system that is not conveniently available or affordable in terms of time for many of us. And that is a symptom of a sick care system that needs to be fixed. So let's use that same diagram and apply it to healthcare. So as I said, we've got this centralized solution source in the middle that I would call the general hospital. Over time, we've basically embedded into it a lot of these services. And basically, it's been this one-size-fits-all, we serve all type of solution shop. But if decentralization were really to take effect in healthcare, what we would need to see is, first of all, things that we're doing in the general hospital today, we need to keep pushing them out and saying, are there things that we could in fact be doing in an outpatient setting? Now, we've done some things like this. We've pushed some things out into the outpatient world, certainly primary care, or same-day surgeries and ambulatory facilities, but we need to intentionally do more of it. At the same time, are there things that we're doing today in an outpatient facility that we could in fact do in an individual office or even a kiosk or a retail setting? And are there things that we're doing there that one day we could do in the patient's own home? Or better yet, in a mobile setting, so it goes wherever the patient goes. But it's not just about changing the venue of healthcare, it's also changing about who manages that healthcare. So in the center, we're accustomed to having a whole assortment of very highly paid experts. And the question is, can we move away from that very expensive model and take some of that expertise and put it into the hands of a solo practitioner? Or are there things that solo practitioners are doing today that we could in fact enable really a whole assortment of allied health professionals, folks like nurse practitioners and physician assistants, pharmacists, really a whole set of underutilized healthcare workers that could do more given the right tools and technologies. But ultimately, if we were to reach that outermost ring of non-consumption in healthcare, we need to figure out ways that we can empower our patients to do more for themselves. So this is sort of the map. It makes a lot of sense, but when you compare it to what's happening in computing, we are far behind in terms of what needs to be done in healthcare. Just as a quick example of how disruption and decentralization in healthcare affected me and my practice, this is an article I pulled from 1983 from the Annals of Surgery, and it is basically a review article of a long-term study that they were doing looking at ulcer surgery. So for a long time, if you had a bleeding ulcer, or a bad enough ulcer, basically surgery was your only option, right? Somebody had to go in and cut that ulcer out or stop it from bleeding. And in fact, so many people were getting ulcers in this era of the 1960s and 1970s that basically they said, look, this is crazy, surgery is so expensive, we got to figure out how to make surgery better and better, decrease complication rate, decrease our length of stay, so that everybody can one day get surgery, because everybody eventually looks like they're going to need it. Now, what's interesting is that this article was submitted in 1982, which also happens to be the same year that a couple of researchers from Australia rediscovered this notion that ulcers, for a large part, were caused not by stress or whatever people were thinking in those days, but in fact by bacteria known as Helicobacter pylori. And this H. pylori bacteria, if you could wipe it out with antibiotics, could in fact cure most people of their ulcers and never get to the stage where they were bleeding and eventually needed surgery. Now, just as a quick fun fact, Dr. Marshall actually was a little bit infamous because he gave himself ulcers by drinking a petri dish full of this stuff to prove his hypothesis. And did I mention he was Australian? But don't worry, his reward was he won the Nobel Prize in medicine. So this discovery basically led to a lot of other technologies. First of all, you got a whole panoply of diagnostic tests available to somebody like me, where I could order it on a whole assortment of tissue and bodily fluids, where I could figure out if this person was indeed infected with H. pylori and this bacteria was the cause of his symptoms. At the same time, I could prescribe a simple package of antibiotics and antacids to cure him of his bacterial infection. And so what, in fact, I was doing was disrupting the surgeons. So the surgeons were over here trying to figure out how do we get better surgery so that we can treat everybody. And at the same time, a non-surgeon like me, given these new diagnostic tools and prescriptions, I could now treat a whole assortment of patients. I couldn't treat the bleeding ulcers up here at the top, the more complex cases. Those guys were still reserved for surgery. But just like the PC or the laptop, I basically came out and helped some of the simpler patients with earlier infections that I could eradicate. Now, understanding disruptive innovation, that theory that I showed you early on, basically gives us that crystal ball to make predictions. And as I said, in writing a book on the future, it's very intimidating to come out with predictions, but as time has gone on, this idea, disruptive innovation, has given me more confidence because it's proven right time and time again. Basically, what I can tell you already is that if the theory holds, what it would say is that if this practice of prescribing antibiotics is as simple as we could make it, well, maybe it doesn't take a medical degree to do this stuff anymore. That ordering a test for somebody with indigestion or acid reflux symptoms, and then prescribing a simple package of antibiotics and antacids could be done by a non-physician. Or, better yet, if you're in a part of the world like Southeast Asia, where H. pylori is endemic in the population and basically runs rampant, could we in fact give access to some of these diagnostic tools and even the antibiotics to patients directly? Because if your hope as a public health person in Southeast Asia is to get rid of this disease, there is really no way for you to eradicate that disease by funneling everything through your doctor's office. There's just not enough, there aren't enough doctors, there aren't enough slots available to get rid of this disease. The only way is to get these tools into the hands of patients. So this is the path that disruptive innovation would predict, and it's sort of what I showed you on the concentric circles earlier. Now, it's not just infectious diseases and it's not just Southeast Asia, but we have already done this. And we have our own endemic diseases in this country, things like diabetes, and we have handed tools to our patients so that they can manage more of their condition on their own. And so how crazy would it be if we still had to funnel all of our diabetics through doctors' offices to manage their day-to-day blood sugars? But of course we don't do that because we've given diagnostic tools, basically these glucose meters, to our patients so that they can track their sugars according to their diet, their activity level, and even be able to adjust their medications multiple times a day as needed. This idea of handing over tools to non-experts is actually not unfounded. It's not something unique to healthcare in the form of glucose meters, but we ourselves have benefited from this trend of consumerism, where with tools like online travel booking from folks like Expedia and Travelocity and Orbitz, we no longer have to visit travel agents for each and every travel issue. If you have a real complex itinerary that you want to plan out, well, that's when you would visit the travel agent. But for all the simple trips, we tend to book those on our own now. Same thing for tax preparation. More and more of us are using tax software to prepare our own taxes. And if you have really complex taxes, well, that's when you would hire an accountant. So basically what disruption gives you is choice in the marketplace. And an interesting example comes from the world of banking. So the automated teller machine. If you think about it, the ATM has been great for consumers, right? We can now access our money really any time of day instead of just waiting for banking hours and the bank to be open before you can access your money. But at the same time, we're actually doing work for the bank, right? The bank used to have to pay tellers to do what we're doing for them now at the ATM. So it's been great for banks too. And in fact, it's allowed banks to really open up, a mini branch where they previously couldn't sustain a full service branch. And it's made banking that much more accessible to everyone. Now, the tool that's going to allow us to do this in many ways in healthcare is the smartphone, right? The smartphone is sort of that ATM device where we can implement healthcare anywhere, and it goes even better than the ATM. It goes wherever the patient can go. And it would be a shame not to take advantage of this as our new platform to deliver healthcare. And we're already seeing a lot of activity. So now I'm going to start talking about some of the trends and technologies that I'm seeing out there that are really dramatically changing the landscape of healthcare. So the first thing is that by some estimates, there are 40,000 health and medical apps already out there. Most of it, I'll admit, is junk. And so it's a problem because much like in the early days of healthcare, you worry about snake oil salesmen really disrupting, in a bad way, the app industry for healthcare. But Haptique is one company, for example, that came out of the New York Hospital Association, and they are trying to curate apps and trying to organize them in a way so that one day physicians can prescribe an app much in the same way that we prescribe drugs today. So given your particular case history, your symptoms, and you know, the way you interact with your smartphone, this is the right app for you. And you know, with the same level of personalization that we try to do with drugs. There is also the iPhone ECG. So there's a snap-on case that you can put on the back of a smartphone and basically put it right on your chest wall and get an instant EKG. Now, if you talk to the founder of this company, he says the FDA limits me right now to selling it to healthcare professionals. But I've tried to make it so affordable that one day I hope that this is something that everybody just carries around. And basically you have a continuous Holter monitor with you at all times, and it can alert you if something's going wrong. And this is the smartphone-based ultrasound. And so this is the first FDA-approved ultrasound based on your smartphone from Movesante in Seattle. And basically what's brilliant about them is, you know, in the old days, you had to build a whole, basically, computer to do ultrasounds, right? You had to have a display screen, you had to have processing power inside that machine. But basically, Movesante, all you have to do is make this dongle on the right that's compatible with your phone for a few dollars, right? Everything else, the screen, the processing power, it's all subsidized by the telecom industry. And they have their own reasons to want to introduce better and better screens and processing power, so that's no longer the problem of the ultrasound industry. And you're not meant to be able to read this, but this is a diagram from a tech magazine that basically just highlighted all the medical sensors and or medically applicable sensors that are already embedded in your everyday smartphone. So two of the things that I just described, the smartphone ECG and the ultrasound, are in two of these boxes here, but there are actually many more things that your smartphone can do. And where this is all leading us to is this idea of the handheld hospital. There is actually a competition out there sponsored by the X Prize Foundation with a $10 million prize put up by Qualcomm that basically hopes to spur innovation around this idea that you can build a actual working medical tricorder. Now, for those of you who aren't Star Trek fans, the tricorder was the device that the doctor would basically wave in front of the patient and it would give him an instant diagnosis. We have a technologically advanced device in the form of a smartphone that everybody already carries around with them. Can we, in fact, use the sensors and technology already in there to constantly monitor people carrying around these smartphones and let them know when something's going wrong? Because how much better off would we be not having to rely on our pain sensors? Because that's the only sensors that we use today. And in fact, as I said before, we go through that internal monologue, but the pain has to be bad enough before we want to seek care. Now we have a device telling you that even if you don't feel pain, there's something gone wrong and you might need medical attention. Or if you happen to feel pain, it can tell you that all other systems look okay, you're okay to go. Other things that are driving you know, consumerism are information, transparency, and empowerment. So things like Open Notes, this is a project that is promoting access to your medical record so that not only do you get to read what your doctor has written about you, but also one day edit and contribute to it. And Open Notes has already found some interesting things out of this project. Not surprisingly, a lot of doctors were worried about this, and they opposed releasing medical records to patients, even though it's your record. They said that the notes they were writing could be subject to misinterpretation. It could create a lot of patient anxiety. But really, what the project has shown is really the opposite. First of all, this supposition that nobody was going to read it, nobody would access it, proved untrue. Everybody accessed their health record at least once, and many of them multiple times. But there were also some very interesting case studies that came out of it. For example, one person said, I found a medication list error that, this medication list didn't belong to me. Another person found an entire visit note that didn't pertain to them. They said this was written about somebody else. I don't know why it's in my medical record. And all of that obviously can lead later to problems with your own payment and reimbursement and your medical history, et cetera. And then there was another woman who said, you know what, I never really thought about getting on a diet and fitness regimen until I read morbidly obese in my note. And then that really changed my outlook on my healthcare. Then you've got things like Healthcare Blue Book that's promoting transparent pricing and built into EMRs like Dossier and portals like Castlight that are trying to give pricing and quality data transparently to employees and patients so that they can make better decisions, not just for themselves, but also on behalf of the self-insured employers that often sponsor these sorts of things. And I know ABMS has been pushing their own platform that involves, I think, Dossier and Healthcare Blue Book, and basically promoting a lot of this issue of information and pricing transparency so that everybody can actually make better decisions. And really what we're driving towards is this new ecosystem of disruptive business models. So as we move outward, we're taking advantage of some of these new technologies in green. In the book, I won't get too technical, but in the book, basically, we call these technological enablers, right? They're not necessarily medically related, but they're things that allow us to open up new business models. Really, where I want to focus the rest of the discussion this morning is on these disruptive models out here in blue. And this is, again, just the ones that we've had a chance to document and visit around the country. But I'll highlight the ones that I find most interesting, starting with hospital at home. So one common criticism of disruptive innovation is that because you're really starting out with some of the simple things, that you're typically only going to be able to fix things having to do with vaccination or upper respiratory infections or earaches, and you're never really going to get to the high-cost things, which is what most people want to fix. But hospital at home, I think, really shows that disruption can take care from the center all the way out to the margins. So hospital at home is an idea first pioneered by Johns Hopkins. And basically what they were saying was, given the technology that we have at our disposal today, are there things that we're doing in the hospital that we could actually do in the patient's home? And so when a patient shows up in the emergency department, and normally we would have admitted him, can we send that patient home now with the right technology and care visits so that we can, in fact, give equal, if not better, care in the home? Now, that was an especially appealing idea to Presbyterian Hospital in New Mexico. So Presbyterian was facing a dilemma that many hospital systems face, and that is that their hospital beds were constantly full. They had patients in the hallways, they had patients overflowing in their emergency department. So one common solution is you build another hospital. But history has shown us that that hospital eventually gets full. Then you got to build another hospital. And that is, of course, a very expensive way to continue to fulfill this demand for hospital care. So Johns Hopkins' method actually promised a way out. They said, rather than build a hospital, can we, in fact, start using people's own beds as the hospital bed? And so Presbyterian very eagerly adopted this and tested it to see if it worked. And what they found in this article that they published in Health Affairs last year was, in fact, a lot of conditions for which they used to admit, including a pneumonia, COPD, or CHF exacerbations, could now be taken care of safely in the home. Not only was it as safe, it was safer, and it was better, and it was cheaper. So what they found was a 19% cost savings, first of all, a shorter length of stay, so people recovered quicker at home. They were less susceptible to hospital-acquired infections, of course, because you didn't have other infected patients around you. And of course, not surprisingly, patients were delighted. They were much happier to recover at home. And so they estimated a 19% savings, and that was a dramatic underestimation of the amount of savings actually realized because they, of course, didn't have to build a whole new hospital. So all of those costs weren't even considered. So just a direct head-to-head comparison, it was already cheaper, even without thinking about building that hospital or the savings of not building it. Now, once again, like any classic disruption, it doesn't fix everything, right? If you have sepsis and you're in full-blown shock and you need ICU care, we're not going to send you home. That's when you actually need the hospital bed. But the ability to transfer some of that some of those patients to a different facility that is lower cost, more accessible, and more affordable basically means that we can preserve our hospital system for people who need it the most and create these new business models to serve everybody else. The next one I wanted to highlight was retail clinics. Now, retail clinics have been around for a while. It's something that we wrote about even in the research for our book, and it's something I know EBMS has been involved with. But just as a quick view from my perspective, it's actually interesting because, again, we're accustomed to this healthcare model where you have one facility or one health system that promises to be one thing or promises to be everything for everybody. And this one-size-fits-all model is, as I said, very complex, very expensive. It is that centralized model. So MinuteClinic basically went the complete opposite and said, look, we're going to post a menu on our wall, no appointments necessary, fixed price, but we can only deal with these 18 or so conditions. Everything else, we're not going to handle. If I were to come up with a corollary in the business world, it would be, for example, a Jiffy Lube. Jiffy Lube does not claim to be able to do all things for your car. Your dealer will, but your dealer is sort of that centralized mainframe, and it's expensive. If all you want is oil, lube, and filter, well, that's when you go no appointment necessary, pay a fixed price, and go to Jiffy Lube. MinuteClinic is that corollary in the healthcare world. Next, about worksite clinics, something else I think EBMS has been involved with. There's an interesting example that comes out of Wisconsin. There's a company out there, a self-insured employer, called Quad Graphics. Quad Graphics is just like any other software company, and like most self-insured companies in America, they were facing a problem with their healthcare. That is, costs were skyrocketing out of control. And in return for all of that money they were paying, they were getting crappy quality in return. So Quad Graphics did what they would do with any supplier to their company. They fired their supplier, they fired their healthcare providers, and basically said, what we're going to do instead is we're going to build our own. And so they actually built their own clinics, they hired their own primary care doctors, not just to take care of occupational health, which has traditionally been what employers are interested in, but they wanted to take care of primary care to also make sure the long-term medical costs for their employees didn't keep going up. And so Quad Graphics basically, by building their own primary care clinics, hiring their own doctors, were able to keep costs in check, and in fact did such a great job that they had other companies in their neighborhood knocking on the door and saying, hey, can we fire our healthcare supplier and start using you guys? And so eventually it became big enough that they spun out this company now called QuadMed. And QuadMed serves not just Quad Graphics, but serves Briggs & Stratton and other companies in their area, all self-insured employers who want to keep their costs in check and haven't found the right solution coming from the traditional healthcare system. Now, it sounds unusual for a healthcare system to basically come out of a large employer, but if you go back in time long enough, you'll see that Kaiser Permanente started this way, where Kaiser basically built their own model for their employees and eventually opened it up to the community. And in Texas, you've got Scott & White. It came out of a railroad company that built its own model and later opened it up to the community. So it's actually not that unusual. And in fact, some of our biggest systems and our most successful systems have grown out of this pathway. Next, I wanted to talk about telehealth. So one other dramatic disruption that's going on in healthcare. Telehealth has a PR problem because people look at telehealth, this idea that you would virtually visit with your doctor. And the PR problem is that a virtual encounter is not as good as a physical, real live encounter. And therefore, it is automatically considered to be inferior, and people say it should be paid less. And that's a problem, because the question about disruption is that people think of disruptive innovations automatically as inferior because it's serving a less wealthy market, a less educated market, or basically non-experts. And people say, well, it's just a simple tool for people who can't afford any better. If you have a real live doctor, why wouldn't you want that instead? Well, think about this guy on the right. And basically his condition prevents him from being able to go regularly to the doctor. And he's missed a number of appointments because of it. And for him, the question is telehealth actually an inferior substitute, or is it in fact a superior substitute for what he's currently offered? So I would basically say that for non-consumers out there, there are in fact ways to give you a disruptive innovation that is not just an inferior substitute because it's cheaper, it's actually a superior substitute because it meets your needs. One other, I think, fantastic application of telehealth was one I saw in the United Kingdom. So in the UK, you've got the National Health Service, universal coverage, everybody's got insurance, everybody's got a doctor, including a general practitioner who you've probably known your whole life. I talked to a telehealth startup out there, and in their early days, they were trying to figure out how are we ever going to introduce a service in the UK that people are willing to pay out of pocket for. Because if it's truly just an inferior substitute, or even an equal substitute, why would anybody pay for it when they already have free healthcare down the block? And then they realized and looked at the market and said, there are, in fact, pockets of non-consumption out there that we can target. People who would very willingly pay for a telehealth service. And so what they chased after were, starting off, were patients who had questions about sexual and reproductive health and questions about mental health. These were, in particular, patients who didn't want to talk about these problems with their lifelong general practitioner out of social stigma and other reasons, but basically, they were willing to pay for the relative privacy of a telehealth encounter. And even in a country that had universal health care, there was a pocket of non-consumption that this telehealth company targeted to start off with. Grew from there, eventually expanded to other conditions where people realized that it was not just useful for embarrassing questions, but useful just for purposes of convenience, that you could do it in your own home and not have to wait for an appointment. And basically grew from there and eventually got bought by Lloyd's Pharmacy and is now Lloyd's Pharmacy and also Walmart in the UK, their biggest telehealth provider. And then there's an interesting example from New Mexico, which took telehealth really in an entirely new direction. They basically encountered this problem where they were getting referrals from all over the state for hepatitis B and hepatitis C cases. And the lead hepatologist, Dr. Aurora, there in the center, basically had this problem. He said, look, telehealth is only going to help me in so many ways. It's going to force me to start seeing patients after hours and on weekends, and it's going to destroy my life. But basically, I don't know how else I can use telehealth to see more patients and get these people the care they need. There's no way I'm going to finish this backlog of patients otherwise. Meanwhile, you have patients traveling hundreds of miles from all over the state, waiting weeks and weeks for appointments, so it wasn't a great solution. So telehealth couldn't fix that, at least not the way it's normally applied. So he said, how about I start seeing patients together using the same telehealth and telecommunications equipment that I was already given, but I'm going to see patients together with the community providers, including the nurses and primary care docs and physician assistants, who previously were just referring en masse to me. And hopefully by seeing these patients together with them, I can also educate the provider at the same time. Get their skill level up, get them comfortable managing some of these more basic cases of hepatitis B and C so that they don't all have to refer to me at the university. And so his article in Health Affairs last year also showed this growing ability and capability of these providers out in the community to manage some of these simpler cases of hepatitis. And so without even knowing it, Dr. Aurora had self-disrupted. He had basically offloaded all of the simple cases of hepatitis back out into the community so that they no longer had to be referred to him. And the only patients he was left with were the really complicated patients that really deserved his attention. And it was so successful that Dr. Aurora basically opened up this program to other conditions, including HIV. And then Robert Wood Johnson Foundation got wind of this and basically said every hospital should be doing this. So they piloted it at a few more hospitals. And now the VA has decided to pilot this and hopefully one day expand this to all of their hospitals. And borrowing a term from the military, Dr. Aurora called this the force multiplier effect. That this idea of trying to serve all of these patients, there's no way that you can fulfill that demand by simply hiring more hepatologists and more experts, or even if you had the ability to do that, it would be extraordinarily expensive. But really the best hope for solving this demand is to train other providers that perhaps may not have the same skill level, but at least can handle some of the simpler problems so that the really top level experts can focus on those conditions really where their energy is needed. With home monitoring, again, this is interesting because you have a lot of sensors and consumer medical devices that are out there that could really dramatically change how we take care of our patients. There's a company in Texas called CareCycle, and basically they were a typical home health agency. And they sent nurses out to people's homes to check on them, make sure they were okay, especially after hospitalization. And if there was any sign that the patient was declining, they would refer them back to the emergency department or send them right back to the hospital. But the nurses could only visit so many times. I mean, once a week, once a day, but really couldn't be there continuously. So the CEO of this company, on his own dime, basically said, look, this is poor care, so what I'm going to do is I'm going to start putting sensors in these people's homes. So I'm going to give them Wi-Fi connected scale, for example, if they have CHF conditions, so that it's constantly monitoring their weight. I'm going to give them vital signs monitors that are all connected to my central command station. And now I can monitor everybody continuously, and I know not only when they're in trouble, I also know when they're fine and I don't have to send a nurse. Because there were a lot of wasted nurse visits before where patients were actually doing just fine, but we had to do those periodic checks because that was the only way we could monitor those patients in the past. So now he knows when patients are well. He knows when to send a doctor. He knows when to call them and say you need to go to the hospital now. And basically by doing so, by putting these sensors out in patients' homes, he's reduced rehospitalization rates dramatically. So this idea of decentralization and disruption basically leads to this explosion of innovative business models. All of these models in the blue not only change typically the venue where healthcare delivered, it changes who delivers that healthcare. By doing those sorts of things, you make healthcare so much more affordable and conveniently accessible that this debate of how do we afford healthcare for the nation really, I think, becomes a secondary issue. And so I know EBMS has helped promote a lot of these sorts of models in blue. I've shown some others that I don't know if EBMS is involved, but hopefully they will be. But hopefully I've given you a bit of a glimpse into the future of healthcare, some of the models that are coming. And again, I'd encourage you to use disruptive innovation to your own devices, and it will help you, I believe, see the future when you spot something new and say, that's really going to change healthcare. Thank you so much.
Indeed. Indeed. Let me come on back up here, would you? Give me, there we go. One more time, Dr. Jason Hwang, ladies and gentlemen.
Thank you.
So, Doctor, we're going to open it up to the audience here for questions. And I'll tell you what, I've got a question just to get us started. You mind?
Not at all.
All right. Here we go now. Listen, putting healthcare in the hands of patients, gives me a little more sophistication, I suppose. Putting healthcare in the hands of patients can be kind of dangerous, all right? I mean, every time I go out to WebMD, I'm convinced I've got to go for the mouth disease, all right? Now, I'm not saying I'm a hypochondriac, but do you think disruptive innovation offers too much information and control for patients to handle responsibly?
Again, it's a great question. There is clearly a danger to giving more control into the hands of non-experts. And it's a debate that I think we've seen time and time again in other industries where we've handed more power over to patients. Now, one thing is that you need to be a skeptic when you're getting an opinion only from the experts of the industry who are the ones being disruptive, right? Stockbrokers did not want to be disrupted by Schwab, and they said you're going to make mistakes if you conduct your own trades. Banks were initially opposed, in fact, to ATMs and later online banking because they were afraid of patients making mistakes. And if you talk to a travel agent or an accountant, they're going to tell you should hire me because no piece of software and no online booking agent is going to replace what I can do for you. I think there are clearly some dangers that we need to make sure that, especially in healthcare, when we introduce a disruption, they are done as safely as possible. And that is any technologies or tools that we hand over to non-experts needs to be as easy to use, as idiot-proof as possible. But there are also some really neat things that we can do with disruption. So Mobisante, that company that introduced the smartphone-based ultrasound that I showed you, one big fear of the CEO of that company, he's Indian, was that, look, I know the dirty secret of India, or perhaps not so dirty secret, is that there are a lot of back alley abortions done on female fetuses. And I really worry about what would happen if I made ultrasound suddenly so affordable that everybody in India suddenly had access to it. But then he also realized, unlike every other ultrasound device that's ever been made, my device is connected 24/7, and I know anytime my device is being used, unlike all other ultrasound machines. And I know where it's being taken, and I know when people make decisions that are immoral following the ultrasound. And if the government of India ever wants me to help them track these people down, I can help them do it, unlike anybody else. So again, I think there are ways to also even solve some of the dangers that we've had in the past with these sorts of disruptive technologies.
It's a good idea. Kind of keep the patient tethered to healthcare professionals somehow. All right, any other questions in the audience, ladies and gentlemen?
Yes.
Application for automated kiosks, where are you seeing that?
So application in automated kiosks. Right now I see, I think Walmart has been trialing some with American Well, and I also know there's a pilot at UCSF in California. But basically this idea where a kiosk is a nice go-between telehealth care, where something can be done completely virtually, or an in-person visit. So I'll give you an example. Telehealth is great if you don't need to actually see or touch anything. So it works for dermatology, where you can snap a picture of the mole or something to have it looked at. It works for radiology and pathology, where you can just send images. But if you actually need to touch something or visually in-person see something, it doesn't work well. The kiosk is a nice go-between, because a kiosk works for things where you might need to collect a sample. So if you're in a Walmart where there's a pharmacy, somebody can actually, the pharmacist can perhaps one day help you take a blood sample, or you can collect a urine sample, much as I don't like to think about that happening in Walmart. But you can actually do things that actually require physical contact, but still not have to go all the way to the level of an actual physician's visit. And again, the whole idea is to make it as automated, as straightforward as possible, and reduce that level of human involvement if possible, because that human involvement comes at a great cost. It is also, when you remove that human element and make it automated, tends to be much more reliable. So, you know, your accountant will tell you that TurboTax can't do everything he can do, but you have to hope he knows what he's doing. And not all accountants are equal. And so your luck of getting a bad accountant versus a good accountant basically goes away with something like TurboTax, because it's uniformly standardized for everybody. So I think that's the advantage of automation and the advantage of kiosks. Yes?
So in the fee-for-service world reimbursement, that was today, do you have any thoughts on provider reimbursement and how that might change?
Yeah, so the problem with the reimbursement system is that it's almost like concrete poured into the system, that it keeps everything in place, and that even new innovations that come into the marketplace are almost forced to try to seek some sort of reimbursement bucket, and it funnels them into the same slot that just basically causes nothing to change. So really it requires a lot of payment innovation to spur along some of these things. And there's a lot more in the book, and I didn't really get a chance to address it today, but a couple things I want to point out. First is improving the consumer role. So I talked about giving more information to consumers so they can make better decisions. But you also want to give them some financial incentives. So health savings accounts, again, I think something that EBMS has tried to help push forth. Health savings accounts actually do quite a bit to encourage patients to have some shared responsibility in medical decision making. At the same time, on a higher level, what we've seen is most of these disruptions, in fact, that diagram of all these disruptive models came out of a research project that we did looking at a specific type of health system that we called an integrated health system. An integrated system is basically any health system that not just provides care, but also is a payer. So it's responsible for the bottom line as well. And we found that that created a unique environment, because suddenly you have people that needed to ensure their care was cost effective, but they couldn't just deny care because you need to keep people healthy so that they would keep renewing it year after year. And so disruptive innovations we found most often arose in those sorts of systems. Your prototypes would be folks like Kaiser Permanente, Group Health Cooperative, Health Partners in Minnesota, those sorts of entities. So I think that's one other type of payment change that I think where we would see a lot more disruption come about. Yes?
I didn't quite follow that. So would you say the third-party payment mechanism inhibits this sort of disruption, or do you think it's Kaiser?
Yeah. So I absolutely think the fee-for-service third-party reimbursement tends to inhibit this. Really, the most disruptive innovations we see come out of situations where there's also tremendous payment change. Kaiser Permanente, even though their payment model has been fixed since World War II, really has a unique payment model where basically they collect membership fees from their patients, and from that global pool, they divvy up how they believe people should be paid. And if they want to hire a community health worker who's somebody in the neighborhood to be a peer educator, they can do that. Whereas your traditional medical clinic or hospital will just see that as a pure cost. They don't get much benefit from preventing things. In fact, they probably lose business if they have people stop coming in sick. Whereas Kaiser does actually make money by keeping people healthy and out of their hospital. And so that sort of payment methodology does work. But not everybody can be Kaiser. Kaiser and Kaiser-like models, I think, serve 5-10% of the population. We should see more, but there are other models like health savings accounts that I think could help us spur on disruptions beyond Kaiser. Yes?
Thank you for your presentation. It's very thoughtful. How do you see the best way to educate consumers and probably non-consumers about the value of having their health care pushed out from the hospital, maybe ultimately to a solo practitioner, when they might feel that it's a lower level of care?
Yeah, how do we educate consumers about some of these new options, especially if it's considered a lower level of care? To be honest, not to be glib, but I think we have to do more education to the provider side, because it's the providers that are often accusing these of being lower quality. In fact, I think there's actually a new paper that just came out in JAMA or PEDS, JAMA PEDS, basically saying that consumers have very willingly adopted this despite the objections of providers. And it is because this perception of quality is in the eye of the beholder. So is quality basically going to a pediatrician but having to wait hours, if not days, to get your baby in to be seen for maybe an earache? Or if your baby is somebody who has had earaches several times and you recognize the symptoms, all you want is a quick check and an antibiotic prescription, in that case, I would say quality in the eyes of the mother is much better at a retail clinic. So I think it is appropriate to challenge quality if retail clinics ever started trying to do cardiac surgery, but they're not going to do that. So again, I think the opposition that you see and the criticism that you see from the medical world, from the provider side, really is based on this unfounded belief that nobody can replace me. Nobody can do the things that I can do. And I'm not arguing that. I'm just saying some of the things you do could be done by somebody else.
All right, Doctor, we have time for one more question. Is there one more out there?
If you guys have any other lingering questions that you forgot to ask, please do feel free to reach out to me via email or Twitter. Thanks.
We put that up under yes. Give it up, ladies and gentlemen. Dr. Jason Hwang. Thank you, Doctor.